So conflict of interest, I have royalties from 3 sources, my own corporation because I self-published the workbooks, Guilford Press and American Psychiatric Press. So, as I said, we'll start out by talking about how bipolar spectrum disorder presents in children, then the biological, then the psychosocial. But we need to make some preliminary comments. You've probably all heard about the controversy about diagnosing bipolar disorder. The new book just came out that the title is Your Child Does Not Have Bipolar. So what's this all about? Well, first of all, there's been a lot more attention. I started graduate school in the early 1980s, and those of you who are graduate students, you'll appreciate this. I could put all of the articles written on the topic into one file folder, and I could read every single article on the topic and not be overwhelmed. Okay. You couldn't do that if you started today. It would be a lot more work. So there were 26 articles before 1980. That went up to 36 during the decade of the 80s when I was in training. See, you can imagine all those in one nice little file folder. That doubled to 66 in the 90s and went up to 46 in that 2-year interval, which is when we published this review, from 2000 to 2002. And as you can imagine, it's just gone up exponentially since then. Amazon search for books, there were 15 published in the 3-year period from 2000 to 2003. That's continued to increase. Websites, 5 since 1999. We've been on multiple cover articles. The first time you get on the cover of a major news magazine, you know you're really kind of out there. And now we've had lots of covers, Time, Newsweek, U.S. News and World Report, etc. Google Internet search for a chapter we published now over 5 years ago. You see the range is down from 250,000 for childhood mania to over 3.5 million for adolescent depression. Anything that you do on the internet gets dated very quickly, so this is like prehistoric data for you now because it's 6 years old and it's for the internet. You've probably all heard quoted, or more likely misquoted, the Moreno-Olson et al. Study on national trends in the outpatient diagnosis and treatment of bipolar disorder in youth. And what they did in this study is compared outpatient visits in 1994 to 1995 and 2002-2003 for individuals 0 to 19 compared to those 20 and older. They had demographic, clinical, and treatment characteristics, and that they compared in those 2 time periods. And they looked at patient visits, not patients, but how many times. So if I'm a patient and I visited 10 times, I got tallied 10 times, not 1. Okay. From the National Ambulatory Medical Care Survey. And they estimated the annual number of office-based visits for a diagnosis of, so what did you code as your primary reason for the appointment, and if bipolar was your #1 primary diagnosis, youth in 94-95 had 0.0025% visits for bipolar. And so the big headline that splashed all around the country was 40-fold increase in the diagnosis of bipolar disorder. Okay? It went up to 1%. Now, in my introductory textbook for statistics, when I started graduate school, on the inside, you know, where they always have those little pithy sayings, was there's lies, damned lies, and statistics. Okay, this is a great example. So there was a 40-fold increase. It went from 0.0025% to 1%. Adults went from 0.9% to 1.7%. What did the authors actually say? Because they were routinely misquoted. It is possible that pediatric bipolar disorder, previously underdiagnosed, is now being appropriately recognized at earlier ages. The median age of onset of bipolar disorder has been located between age 19 and 23 years, indicating that in 50% of patients, the illness starts at a younger age. Long delays in treatment seeking have been previously documented when the onset occurs in childhood or in adolescence, perhaps owing to problems with clinical recognition. In recent years, there has been an increase in academic attention devoted to pediatric bipolar disorder. In addition, childhood bipolar disorder has been regularly featured in the popular press. These developments may have raised clinical and public awareness and promoted appropriate treatment seeking and clinical recognition of the condition at earlier ages. Now, that's what the author said. That is never quoted in the press. So 50% of patients had their onset prior to age 19. The number of patients should be roughly half that of the adult figures. And this suggests not so much the emphasis on the 40-fold increase, but it suggests a 180-fold underutilization of visits in 1994-95. Now, having said that, I will also say that the law of physics applies here. Any good pendulum swings before it settles into the middle. So when I started my training, I was in a unique situation where by my second year of graduate school, I was working with kids with bipolar disorder when nobody else was even talking about it. because it was all pent up over here, there was still, controversy. Could children have depression? Does their superego allow it? They don't have a superego, so how could they be depressed? That was the conversation as I was starting graduate school. So if you couldn't have depression, you couldn't possibly have bipolar disorder. So you see the pendulum, it's all pent up over here. And what happens when a pendulum's let go? Right? It swings, and it swings all the way over here. And so then in certain practice settings, what you get is any child with a rage, whatever that might be, no operational definition, must have bipolar disorder. Well, that's as silly, this side of the pendulum is as silly and as erroneous as this side. So false negatives don't help a child. False positives don't help a child. What I hope you come away with at the end of today's workshop is figuring out how to get your pendulum to swing and settle in the middle, where you don't have many, if any, false positives or false negatives. You want to know how to accurately make the diagnosis. You want to know when it's really something else, and you want to know when it's that plus maybe something else. So what are the comorbidities that might occur? That's where I want you to be at the end of this day. Actually, at the end of this hour and a half, because this is when we're talking about assessment. Okay. So what makes diagnosing mood disorders tricky with kids? Well, what are the mood disorders and what are the child's traits? If my first manic episode occurs when I'm 5 or 10 or 15, I don't know who I am. I don't know who I'm becoming. But if my first manic episode occurs when I'm 25, 35, 45, 55, I know who I am. I know how I function. My significant other knows what I'm like. People in my work setting, in my community, they know how I am. And if suddenly I'm acting really different, I'm going to get feedback. And hopefully I have some self-awareness and will know, gee, I'm really different than I used to be. But if you're 5 or 10 or 15, how are you supposed to know that? How is your parents supposed to know that? I mean, that's the beauty of having children. And if any of you in the room have had kids or had a second child, it's very humbling to have the second child because they're not like the first one. And you think, oh, I guess it wasn't my brilliant parenting. It's something about their temperament, So we really learn that kids are unfolding. And that's the beauty of raising children, because they're like flowers unfolding. We don't know what's coming next. So parents don't necessarily know. Kids don't know. And so it is trickier to make this diagnosis. It's trickier to make most any diagnosis in a child. Okay. How do we tell the ordinary ups and downs from clinical ups and downs? If I'm one of those girls going into 7th grade who doesn't run with the pack of 12 other of my very best friends, but I have like one close friend, I'm a little on the anxious side. And now my best friend, my only friend, moves away, and I'm moving into a new school system where lots of elementaries are merging into a big junior high or middle school. Am I going to be a happy camper the first day of school? Absolutely not. How about the first week? The first month? How long will it take me to adjust? What's a clinical depression? What's an expected response to a difficult situation? How do you make those determinations? A little tricky. What's a normal reaction to a bad event? My parents get divorced. I don't like that. I'm unhappy. Maybe I'm a little agitated. How much should be there? How much is too much? Okay. And then the question that we get a lot, if mom or dad has a mood disorder, whose illness is it? Are they seeing through these gray colored glasses, or if it's a little manicky, are they seeing through rose colored glasses? Are they putting symptoms onto their child? Every now and then in my clinical experience, I've had families coming in when a parent's had a mood disorder. The dad will say, I have bipolar disorder and I know my symptoms started at least by the age of 5. I remember sitting on my front stoop thinking I wished that I were dead. And a 5-year-old shouldn't be having those thoughts. And I would say, I agree, 5-year-olds really shouldn't be having those thoughts. It sounds like your symptoms started early. He's brought in his 5-year-old son to see me because he wants to prevent the pain of his child. And I can look inside and out, left and right, upside down, see no signs of mood disorders. I say, I have good news for you. Number one, I'm not going anywhere. So you can come back and see me anytime problems might erupt. And the other good news is I'm not seeing any signs of mood disorder. So every now and then we'll get that. But that's pretty easy to take care of, and it's very reassuring to the parent. Much more commonly, what we see are parents who also experience that pain of knowing their symptoms started as a child and not getting appropriate treatment. There really wasn't appropriate treatment when they were kids. And now they're seeing those subtle changes in their child, and they're noticing things that if you don't know the kid, you won't know that that's really a different response. And there's something very subtle there. But parents oftentimes, particularly when they have experienced the mood disorder, are exquisitely sensitive to those nuanced signs of the prodromal symptoms. So we want to listen very carefully and respectfully to what parents are telling us. Doesn't mean the kid already has the diagnosis, but it might mean that they're kind of brewing. And so maybe we want to do some preventive work with that family. So again, it's not very commonly that I would see a parent putting the diagnosis onto the child. So how do we want to think about assessment? Rule number 1, take a video, not a snapshot. What do I mean by that? We want to assess behaviors over time and in the child's developmental context. And take your time. If this truly is bipolar spectrum disorder, this is probably a lifetime diagnosis. The stakes are very high, and it should not be considered casually. You shouldn't be able to do it in a 20, 30, 60-minute visit. It's way more complicated than that. You need to do a longitudinal review of symptoms. That's what I mean by the video, streaming video, not a snapshot. You want to determine symptom onset, offset, duration in relation to their social history, treatment history, functioning at home, school, and with peers. And we'll talk some more about that. So what do we do when we're doing a staffing? I do this both in my clinical practice as well as in our research studies. In addition to all the measures that we use in our research studies, there are 2 really important features that you should have in every assessment if you're looking for bipolar disorder. One is having a very careful lifeline. The other is having a very careful family history. So above the line, what are all the things we attend to? Again, those of you who were at the keynote yesterday, you heard the importance of paying attention to those pre- and perinatal factors. What was the pregnancy, labor, delivery like? How old is the child in years, in calendar years, in the grade they are in school? What moves have they had? What life stressors have they experienced? What kind of child care arrangements have they had? How have they done in all those child care arrangements? What school placements have they had? How have they been functioning from preschool on? We not uncommonly will see a 7-year-old who's been kicked out of 5 programs. Okay, that's a pretty good track record for somebody that young because their behavior has been so egregious that places will not keep them. So you want to be able to keep track of all of that. And then you want to look at their symptom history. You want to look at their treatment history. How are they doing at home, school, and with peers? Medical history, some certain things you really want to pay attention to. Allergies, asthma, chronic illnesses, staring spells, injuries, especially head trauma. And you want to look at their treatment for the above. You need, if you see behaviors emerging after a new medicine is brought in, you need a 7 to 10 day washout period for most prescription drugs. And for steroids and fluoxetine, you want to think about a 2 to 3 week washout period. So if you're seeing symptoms emerging after a kid was given steroids, take a wait and see. Put rule out and watch to see if they kind of settle back down. If this is a kid who really should never, ever, ever have steroids, that's something you want to note, but you don't make a diagnosis because they had a reaction to a medication. You want to make sure that there's a physician who's reviewing lab findings, brain imaging if appropriate, and if you have any suspicion whatsoever of illicit use, doing drug screens. Okay. Rule number 2, decide what's in and what's out. The comorbid conditions are what's in, the differential diagnosis, that's what's out. One structured interview, and we've got a sample here today that will help you if you are not terribly familiar with going through the behavior, anxiety, mood, and other disorders that kids might have, would be using a structured interview of some type. Chips we like, again, that was in my conflict. I get tremendous royalties from selling that. Someday I'll be able to buy a book myself from that. But what's nice about the chips is it'll vary in a very straightforward way without a tremendous time commitment, go through a nice structured interview. What it does not do is assess personality, does not assess cognitive capacity, does not assess tic, Tourette, autism spectrum, or panic disorders, never replaces a clinician. Nobody will ever replace you in your work. There's no instrument better than a clinician who can synthesize everything that you get. But it does provide a standardized initial assessment procedure for clinical and research purposes. It's brief, has thorough coverage of 20 disorders and psychosocial stressors. There are psychometrics available for 6 to 18-year-olds. It's very easy to administer, score, and interpret, and the storage requirements are very minimal. For anybody who's done a research case ads, you know that those are big monsters in your file cabinet. Rule number 3, we diagnose children, not families. But families give us very good clues about etiology and also give us very rich therapeutic material to work with in a family. So let's just talk a little bit about genetics. Why do people get mood disorders? Number one etiology, I would say, is a familial transmission, a genetic kind of a basis. So part of that story, definitely genetics. 1 in 3 adopted persons with bipolar disorder have biological parents with mood disorders, compared to 1 in 50 adopted persons without bipolar disorder. If one parent has a mood disorder, you have about a 1 in 4 chance that any offspring will have a mood disorder. If both parents have a mood disorder, you're now up to about a 3 out of 4 likelihood that any child birthed will also have a mood disorder. If I'm a twin and I have depression, I have an identical twin, there's an over 50-50 chance that my twin will also have depression. If it's a non-identical, it goes to a 1 in 5 chance. If I have bipolar disorder, look at the heritability index here, 67 to 79% likelihood that my identical twin will also have bipolar disorder. Goes down to that 15 to 20% if we're non-identical twins. And here you get just a little bit of a sense. This came from our MF-PEP trial. With all of these I've changed names, but in this case the diagnoses are accurate. So you see, let's see if I can get this laser pointer to work. So here, no, that's not working today. Maybe over the break I can get a new battery in this. So you see here, we'll call this girl Jenna, and her mother had bipolar disorder, lifetime and current, also had PTSD, lifetime and current. She was divorced from the father, living with a boyfriend who has untreated bipolar disorder. So think of the home life. So part of what we care about is the genetic etiology, but part of it, just think about home environment. So everybody inside this little area is living together. That's a chaotic household. So on mom's side of the family, her father died of a brain tumor, her mother, bipolar, OCD, phobia, GAD, post-traumatic stress symptoms and panic symptoms. Mom has a stepbrother, half-brother, alcohol, drug, and antisocial symptoms, lots of legal problems. And on dad's side of the family, again, no contact, but you've got the genetic contact, if you will. So his father, alcohol, and his mother, alcohol, so both paternal grandparents, and the paternal uncle, drug abuse and alcohol abuse. There was also a very interesting medical history with this family, but we'll not go into that. But you see the kind of genetic load that is very standard in the families that we see. You'll see lots of substance, you'll see lots of depression and bipolar disorder, and not infrequently quite a bit of panic, particularly OCD. Rule number 4, we want to measure progress over time. Paper and pencil measures. Dr. Youngstrom is really an expert in this topic and has published a couple of years ago a paper about evidence-based assessment of pediatric bipolar disorder. And in his summary, what he reports is that the parent report is the best source of information. The child report actually, when you look at the database, doesn't provide meaningful incremental data. However, I would say always obviously interview the child. You need to understand that child's perspective of their symptoms to work with them therapeutically. Teacher report, we don't have validated information in terms of making a diagnosis, but yet I would say whenever you're doing an evaluation, you need to get teacher input because you need to know how the child is doing in that setting. And part of treating the child is really working with the school system. So you're going to need that inroad with the teacher to get a sense of how is the child doing in that setting and where are the problem areas so that you know how to move forward. One very easy mood chart. We have more complicated versions. This is the most simple and straightforward version where you have a parent just track where the child's mood is that day with a little room for commentary. So what do you want to think about? Again, you want to obtain at minimum information from the parent and child. With the parents, we like to ask about how is the child doing right now? How's the best they've ever done, and what's the worst they've ever done? So you get a sense of that range over time. With the kids, we also ask about current. You can try for best and worst, but there's a very real phenomenon that we call manic amnesia, and we've seen this in our studies where we interview kids over a period of time. When we see them in episode, and they can describe their current symptoms to us. And then when we ask them again 6 months later to describe that period since last interview, oftentimes they can't even begin to describe how they were 6 months ago. They really can't tell us. They're not lying. They're not hiding things from us. They just can't remember and describe it to us. Okay. Adolescents, kind of use your judgment, go for as much information as the teenager can provide for you. What the Geller et al. Studies have reflected is that a third of symptoms are reported by the child only. That has not been true in our database, but it's just, again, something to keep in mind. And I can't imagine working with a child if I haven't talked to them about their understanding of what their experience is. And again, Geller, Tillman et al. Have reported that some of the classic manic symptoms are reported by the child only. We tend to hear it, particularly in the younger kids, primarily from the parents. And you want to use a tiebreaker strategy. So if one source says, yes, this symptom is there, and the other source says, no, this symptom isn't there, look for what are you seeing in direct observation. That's always my first place that I go. The other parent, some other source of information. So if you've got a yes and a no, how do you figure out, do I really count this as a symptom or not? Go for the tiebreaker. And preferably you'll be getting information from the primary care physician, teacher, other clinicians. So we want to think about the FIND criteria. And this came from a paper that we published in 2005. Acronyms, to me, are very helpful for remembering things. So frequency, do the symptoms occur most days of the week? Intensity, do the symptoms cause extreme disturbance in one domain or moderate or greater disturbance in 2 or more domains? The number of symptoms, do they occur 3 or 4 times or more in a day? And duration, are they lasting 4 or more hours in a day? Okay, so those are some criteria you might want to think about. So if you hear about something, but it lasts 15 minutes, a child who gets exceptionally angry once a day for 15 minutes, I wouldn't count it. Note it, and you need to deal with it therapeutically, but would I count that as a symptom of mania? No, doesn't meet FIND criteria. Okay, so what do we want to think about in terms of tracking mood changes? We're going to start with depression, and you probably have a lot of familiarity with depression, but we always have to start with that because that's our building block for bipolar disorder. So normal mood, we all have our good days and bad days, and we wiggle around that middle. Major depressive disorder, as you know, is that big collection of symptoms that lasts for a long period of time. And then dysthymic disorder is what I call the low-grade fever of mental health. It kind of never really goes away. It persists, but it's never terribly dramatic. How about bipolar disorder? BP1 means that you've had a full manic episode. You may or may, technically you don't have to have a depressive episode, but I really never see kids who only get manic who never get depressed. The depression typically uses up more of their days of lifetime than the manic symptoms do. Bipolar 2 means hypomania, and then you do have to have a full depression. And then cyclothymic disorder, a little highs, little lows, you're never meeting full criteria for a hypomanic episode or a full depression, but you kind of are never really without symptoms. And what's interesting to me, there's a study we're doing now called LAMS, the Longitudinal Assessment of Manic Symptoms. It's a 4-site study, and we have the pleasure at Ohio State of following a fourth of the sample. And so we've brought in kids who otherwise I probably wouldn't have clinical exposure to. And I'm finally really following a large, relatively speaking, a larger cohort of kids with cyclothymic disorder. And I'm learning more about what their course of illness is like because I don't have a template in my gut, if you will. So that's been very fascinating for me to be following these kids over time. And then the way we see bipolar disorder oftentimes appearing in young kids is what we call a mixed state, or rapid cycling people will sometimes refer to, and that's when you get the high and the low all smushed into one time. And I can't think of a more miserable mood state than having the energy of the mania with the misery of the depression all together. It's a very intense, very unpleasant kind of an experience. And here's again a quote from a child. This is somebody who had been in our MFPEP study, came in for their last assessment. The mom brought in a school assignment, said, I thought you might be interested. We said, we're very interested. They gave us permission to share. So the school assignment was draw a mask that reflects your personality. And this is what she had to say. And I'll give you just, she had just turned 13 when she did this. And so you read, the black eye represents all the mental punches I get from people. The stars circling above my head represents how I'm confused. My searching eyes represent that I'm trying to find the right path, but I'm lost, so I can't find it. My broken face represents that I'm a broken person. The hair across my face shows I can be whipped around easily. The tears are of loneliness. The crystals equal dreamer, pretender, and the claw in hand equal outcast. I mean, it's just a miserable, miserable self-portrayal. So What are some other things we need to keep in mind as we're thinking about mood disorders? Obviously, symptoms cause distress and or interference with family, school, friends, or work, particularly for teenagers. Or as I like to say, it's a problem when it's a problem. Okay? It's a problem when it's causing problems in your life. Symptoms are not due to other drugs or illness. They're not directly following the loss of a loved one. And they're happening at the same time. It's not one random symptom here, one random symptom there. They're happening at the same time and for an extended period of time. So I'm going to quickly go through MDD. You're probably pretty familiar with this, but you need one or both of impaired mood or loss of interest. Typically, we get both of those. An impaired mood can be sad or anxious, but it can also be very irritable or angry. And you're going to see irritability shows up in many places, so you need to kind of separate out what seems to be the depression irritability, what seems to be potentially manic irritability. And I'm going to try to give you some rules, because otherwise you would feel like you need the wisdom of Solomon to figure out, is it this, is it this, where do I count it? Don't count the same thing in both places. That's one rule you always want to use. Loss of interest, complaints of boredom that far exceed what the experience would expect. Previously fun activities aren't fun anymore, just not getting enjoyment out of life. And then, of course, you need the other kind of impairment, the impaired sleep, appetite, can be too much or too little, poor concentration, fatigue, restlessness or lethargy, worthlessness or guilt, suicidal and morbid ideation. And I'm just kind of buzz through these because I think you're probably pretty familiar with the concept of the depression. Symptoms have to last 2 weeks or longer. What do we know about the course of major depressive disorder? Nice review done by Dr. Birmaher and colleagues from Western Psych. A single episode length on average lasts 7 to 9 months. That's a whole school year. 90% of kids will get well by 1.5 to 2 years, but 6 to 10% say very chronically impaired. And if you're a betting person, bet that it will come back. So in your final session with a depressed child, as you're wrapping up therapy, you always want to go over what are the warning signs and when would you know to come back to see me? How could we nip another episode in the bud? So 40% of kids will relapse by 2 years, 70% of children will relapse by 5 years. Dysthymic disorder, as I said, that low-grade fever of mental health. This is harder to diagnose and less likely to come to clinic as a single diagnosis because it's a little more subtle. But can and should be treated, and we're starting to develop better treatment guidelines around it. So the mood, again, sad or irritable, and then it's fewer symptoms, a little bit milder in presentation, but chronic. So impaired appetite or sleep, fatigue, low self-esteem, impaired concentration and thinking, hopeless feelings. So a little milder. It's that the glass is always half empty kind of a person. What do we know about dysthymic disorder? Here's where it really packs a punch. A single untreated episode can last 4 years. That's all of high school. That's middle school with a year on either end. It's most of elementary school. So if you think about a developing child's sense of who am I, how do I relate to other people, and if I've had a dysthymic disorder for 4 years, that tremendously colors how I interact with the world, how efficacious I see myself as being in various settings, how I interact with adults and authority figures. You can see where this starts to really wreak havoc in the child's developing personality. So we want to get right on this. And adding insult to injury, a major depressive episode usually comes 2 to 3 years after the onset of dysthymic disorder. So here's normal, you're cruising along below normal, and then boom, you really hit rock bottom. This can lead to bipolar disorder and substance abuse. Now, the rates of substance experimentation in high schools, it's kind of scary. Most kids will try alcohol. Many kids try illicit drugs. But most kids don't go on to become alcohol or drug abusers. So what's the difference? If I'm happy with who I am as a person, but I'm at a party and everybody's got a beer in their hand, so I probably have a beer in my hand too. But if I'm not happy with who I am, you know, I'm a sophomore, junior in high school, and I'm dysthymic, and I don't like the way I feel most of the time, I've got a bigger reason to want to use that drug or alcohol to alter my emotional state because I don't like my emotional state. You can see where the risk factor is very high. Seasonal affective disorder. Now in Miami, you're not going to see as much of this, but I live in Ohio, and it's not the fact that it's just a northern climate because I grew up in North Dakota where it's even colder than Ohio, but in North Dakota we had blue skies in the winter, and if you're going to have winter for a long time, you have things to play with. So we would have parkas and sleds and toboggans and skates and all kinds of reasons to get outdoors. If you live in a gray latitude, we're at the bottom 22nd percentile for days of sunshine in Columbus, there are not a lot of reasons to go outside in a gray, damp sky in the middle of winter when there's no snow on the ground to play in. So seasonal affective disorder there is a much bigger topic than you would find here. But what we see in the fall and winter is more of a hibernating depression. So, if you were a bear, you would be in great shape. You could just crawl into a cave and come out in the spring. And it's kind of bear-like, because what you do is you have increased sleep and appetite drive, intense carb cravings. I had a mom bring in her 11-year-old daughter for an evaluation for depression. And as I'm getting the family history, mom who was a postal carrier. Now, can you imagine a better job for keeping in shape? You're walking, you've got all this arm movement going on too, so you're really physically active year-round. Her seasonal affective disorder was so profound that if she didn't really work at it, she would gain 40 pounds every winter, and then it would just fall off her every spring. Now, she was a more extreme case of seasonal affective disorder than many, but that's the kind of just biologic push you hear in people who have a seasonal affective disorder. And in this case, one of the biggest treatments I was able to provide for the daughter, as you might imagine, was getting the mom into treatment for the seasonal affective disorder, which really helped regulate the home life of this girl who also had a mild depression, but her problems were actually far less severe than the mom who had never sought treatment for her own disorder. So we can also never minimize the impact we have on children by making sure that the parents get appropriate care for their own health needs. Again, spring and summer, then non-depressed or manic. Psychotic symptoms, it's really important if you're working with somebody who has severe depression or is at risk for bipolar disorder that families understand that at the highest of the high or the lowest of the low, you can experience psychotic symptoms. This is not necessarily ever going to move or morph into schizophrenia, but it's an index of the severity of illness. So hallucinations, hearing voices, seeing things, sometimes smelling or feeling. When we get the smelling or feeling, we want to do images of the brain. And if you're just hearing your name being called, if you're just seeing something as you're going to sleep at night, we don't get very excited about that. We really don't consider that a psychotic experience whatsoever. We make note of it and follow it, but don't get too excited. But it's when you are really having command hallucinations, telling you to do things like stab your mother with the butcher knife or burn your house down, that we get very concerned. And those are the kinds of things we hear from our younger kids who have psychotic experiences. It is more likely that adolescents experience delusions. We don't see as much of that in the younger children. Again, where you're getting special messages, maybe the radio is talking uniquely to you and telling you to do something. You have special powers or other very unusual thoughts or ideas. Again, these occur in the severity of the high or the low of the low. They tend to go away when the mood disorder is treated. If they don't go away and the mood resolves, now we're moving more into that schizoaffective kind of a realm. But we see fewer kids who have that trajectory. Some do. Suicidal risks. We cannot talk about mood disorders and not talk about suicidality. What's the time that kids are most vulnerable? During or right after inpatient treatment. So if you've had a profound depression and you come to our special club that we call the inpatient unit, it's really important, and our inpatient treatment staff really help kids to understand the course of improvement. Because we know, so we've gone through those depressive symptoms pretty quickly, but they're the somatic symptoms, they're the cognitive symptoms, they're the affective symptoms. The somatic symptoms, the sleep, the energy, the appetite, those improve first. So if you see a kid who comes onto the inpatient unit who looks absolutely like death warmed over, they haven't been sleeping, they haven't been eating, they're just miserable, and after our magic 5 or 6 days on the unit before they're discharged, they start to look a lot better. We say, wow, you're doing great. But if the kid still feels rotten inside, all that dysphoric mood and the hopelessness and the negativity of the cognitions, if those are all still there, and the only message this child is hearing is you're doing great, they think, if this is as good as it gets, now I will go kill myself. Now I've got the energy to do it. So you can see where this becomes a problem. It's very important, if kids have bad depression, that they understand the sequence of recovery. So instead of saying, wow, you look great, say, wow, I'm really glad. I'm noticing, the circles under your eyes, they're getting lighter. It looks like you're able to eat at the mealtime. How are you feeling? Well, that's one of the next parts that's going to start to get better. So help them see that trajectory. That's really, really critical. During a crisis, it's easy to understand why a crisis would be a time of vulnerability. Same thing with following the suicide of a close friend or relative. How many of you in your settings have experienced cluster suicides? Anybody who's experienced that? I'm not seeing any hands going, a little wiggling in the back. When I first came, I've been at OSU now for 25 years. So in the mid-'80s when I got there, cluster suicides were more common than they are now. And this is a place where I really want to give the media credit, because when I came in the mid-'80s, what would happen if a kid committed suicide at one of the local high schools, or sometimes middle school or junior high? It would make the front page of the local newspaper. There would be a segment of the local news devoted to it. And it was this sort of almost glorifying of the deceased. So if you're the best friend or a close friend in the circle of this kid who kills himself, and now the high school does an assembly as sort of a memorial to this child, and you think, yeah, my life stinks too. I would like people to say all these nice things about me. I mean, you can kind of see there's almost like an attraction to it. So after there was some very nice work done on cluster suicides, and we learned as a field, we need to really bring down the media kind of display of that. We need to really ratchet that all down. You shouldn't be doing a whole high school assembly for the deceased. You should have counseling services available for those who need it. And when that really got implemented, and the media was very responsible about this, our rates of cluster suicides in our community came plummeting down, which is good. It's bad enough to have one suicide, but you don't want 3 or 4 in the same school. That's just a miserable thing. Positive or negative life events. It's easy to understand where negative life events might produce suicidal behavior, but positive, what's that about? So let's say I'm 17, I'm getting ready to graduate from high school, and all my friends and all my classmates seem to talk like they all have a great plan in place for where they're going next. But if I'm feeling very unsure about myself, I don't really know what I want to do next, I don't know what my capabilities are, I'm feeling lost. Graduation for me isn't exciting, it's terrifying. Okay. If I'm 15 and I'm going to my cousin's wedding, weddings are supposed to be happy, but let's say I just broke up with my boyfriend and I'm feeling like no one's ever going to love me, I'll never get married. Going to a wedding isn't happy for me, it's stressful for me. Okay? And those are very real experiences. So a positive life event may actually be a very stressful and perceived very negatively by the person. So we have to keep that in mind. Warning signs. If somebody's talking about death or suicide, if they're saying goodbyes, making wills, giving away belongings, act immediately, act swiftly, act intensively. This may be your last chance to save this person's life. These are our final warning signs. What are some other factors that we think about with suicide? If the child is depressed or hopeless, if they've been using drugs, alcohol, if they're impulsive or angry, if there's been physical or sexual abuse, if they've had past runaway attempts, if they've had other just past suicide attempts or non-suicidal self-injury, or if they're perfectionistic. Now, if any of you remember back in the Clinton administration when we had Vince Foster who committed suicide, and when he did, there was a lot of talk about it must be a conspiracy, somebody, he was like too good of a person, whatever that would mean, like he shouldn't have committed suicide. And then after his death, kind of the silver lining that came out of his death was that there was a flurry of research done around perfectionism and suicide. So if you're working with the kid, the kind who just gets wound tighter than tight, and A- isn't good enough because I have to have straight A's, those are also kids to worry about with suicide because they're just so brittle. You feel like if you went like this, they would shatter into a million pieces. Okay, so those are also kids at risk for suicide. And then access to guns. There was a very nice study done at Western Psych by David Brent and colleagues looking at completed suicides and the characteristics of those. And what they found was that if you lived in a home, if a teenage boy lived in a home with guns in the home, they were more likely to complete a suicide rather than make an attempt that wasn't fatal. So when I am talking with families, and here I am, this university lady what would I know about guns and the NRA, So when I'm talking with families, it's like, this is not an anti-gun statement. The NRA doesn't have to come after me. I have no problem with guns. I grew up in a hunting family. I picked pellets out of my mouth every Sunday dinner fall in my life, from the pheasant and the duck and the goose and all that. That hunting is great, no problem. But if you have particularly a suicidal, depressed adolescent male living in your home, it's not enough to just lock up the guns over here and lock up the ammunition over here. You need to get them out of the house. Because in David Brent's study, we found that even when those were locked up within the home, teenagers found out how to get access, and the rates of completed suicide went up. So as a public safety announcement, not an NRA announcement, you've got to get the guns out of the house. Who's at risk for bipolar disorder? We know from longitudinal studies that have been done is somewhere between a quarter to a half of depressed children, if you have your onset of depression prepubertally, you will develop bipolar disorder within 2 to 5 years. But that means half to 3/4 don't. Okay, so what are the risk factors that we look for? And again, these are not perfect predictors, but they give you a good, tree to bark up. If during the depression you had symptoms of psychomotor retardation, the slowing down kind of depression, or if you had psychotic features. If you have a positive family history of bipolar disorder, if you have positive family history of depression on both sides of the family, you're at greater risk. And if you've had medication-induced hypomania, if you're the kind of person who on steroids you got pretty high and loopy, be cautious. Doesn't mean you have the diagnosis, but it means you're at elevated risk. And what are the symptoms that we look for? The mood needs to last for a full manic episode. We need to see 7 days. Hypomanic is 4 days of elevated, expansive, or irritable mood. And then you have to have accompanying symptoms. 3 if the mood is expansive or related. 4 if the mood is only irritable. Grandiosity, decreased need for sleep, and we'll be talking about each of these. Increased talking, racing thoughts, distractible, increased activity or agitation, and foolish or reckless behavior. Okay, so what does this look like? Hypomania, mood change for 4 to 7 days, the same associated features. Functioning is clearly out of character, and the altered mood and behavior will be noted by others. So even in a hypomanic episode that is less dramatic, the kids will have peers come up to them and say, are you taking something? What did you smoke before you came to school? There's going to be some question about what is making you look different. But the symptoms are not severe enough to be called mania, or they don't last as long. Okay, so as we talked about earlier, there's BP1, full mania, and typically a full depression. BP2, the hypomania plus depression. Cyclothymia, the little mania, little depression. And then what is probably most commonly diagnosed, particularly in the younger children, is bipolar not otherwise specified. And we in our setting try to use some very strict research criteria around this. I would encourage you to do the same thing in your practice so that it doesn't just become a catch-all for any kid with a bad temper tantrum or a rage attack. But define why you're giving BPNOS. Possibly because it's one symptom short. Most commonly in our setting and in other research settings, it's because the duration is insufficient, and I'm going to give you some pictures of what that looks like. Or the episode might not be clearly defined. The informants might be a little sketchy. It's the first time you're seeing them, the mom doesn't give you a very clear history, the kid's pretty inarticulate. You're not quite sure what you're seeing. It feels like it might be something in that mood category, but you kind of want to take that wait and see approach, and you want to follow a little bit more over time. They're giving you descriptions of somatic symptoms, but you really want to see it a little bit more before you have confidence in it because they're feeling a little wobbly as informants. Our prototypic BPNOS child in our research and our clinical work is a child who a couple of times a month will have 2 or 3 days where they just don't need to sleep as much and they're like all charged up and there's nothing different in the environment and there's nothing going on and they haven't had any other medications and there's nothing else that would really account for it. But they get really noticeably giddy and silly and telling really, stupid jokes and laughing and staying up late and getting up early and waking everybody up in the family and really noticeably different. But it's like 2 or 3 days and it's a couple times a month and they didn't read the DSM and they don't know that it was supposed to be for 4 days if we were supposed to count it. So what do we do with it? So those are the kids we call BPNOS. And none of them have read the DSM. So they really do not follow those directions well at all. Cyclothymic disorder, as I said earlier, those less severe highs and lows, clearly is causing disruption, but kids tend to not come to clinic with this as their solo diagnosis. Tricky. And we don't have practice parameters around this diagnosis. You're going to hear a little bit later, we've got a study that we've just launched that's looking at kids with BPNOS and cyclothymic disorder. And I don't know how they're going to do in treatment because I don't have a clinical feel for it and we have no research base. So that gives you a little, but I ended up not really talking so much about the bipolar symptoms, so let's go back to that slide. I just want to briefly comment a little bit on that. So elevated or expansive mood. Somebody who normally, and again, this isn't so what you want to be careful of is if you've got, here's average mood, and if you've been depressed, simply coming back up to normal might look like it's manic. So we used to do workshops for the parents of inpatients, and I would kind of bring in any parent whose child had been hospitalized over the past month with any mood disorder and invite them in, and I would do a 2-hour workshop and kind of do a few of these kind of summary slides to help them understand the diagnosis. So then one of these sets of families asked, could they get follow-up care with me? And absolutely sure, happy to work with you and your daughter. 16-year-old girl, had a history of about 4 or 5 years of dysthymic disorder, and then her hospitalization was precipitated, as you heard, with a whole MDD episode that had included a suicide attempt, which is oftentimes the trigger to get into our inpatient unit. So she'd made the suicide attempt, came in, got started on antidepressants, was doing quite nicely, and they come to me for follow-up, and they said, you know how you talked about how depression can go into mania? We think that our daughter might be getting manic. I said, really? Tell me about that. And they said, well, we were just out to eat this weekend at a restaurant, and she talked all the way through lunch. And I said, well, was this the kind of talking that the wait staff were starting to give you funny looks, and the other people at the other tables were starting to, kind of do this? And no, nobody else noticed, but she talked all the way through lunch. I said, congratulations, her depression is lifting. Okay. Which, and these were well-educated people. They meant well, they were doing their best to observe. They hadn't seen this for so long that it really looked almost aberrant to them. Well, what she was doing was coming back to normal, but she hadn't been there for years. She suddenly had the energy, and she liked her parents, she just didn't have any energy, and she was irritable to talk to them for years. So now it's finally getting good again. Fabulous, okay? That's not mania. She was at risk, but she sure wasn't there. So you want to be careful that you're not coming back to normal for somebody who's been depressed. That is absolutely not mania. That is hallelujah, treatment's working, okay? Fabulous. But when it goes up too high, the really slap-happy, silly, giddy, irritatingly giddy, not just somebody who's always missed sunshine in a good mood, lovely, but somebody who, it's a real change in behavior, okay? The grandiosity, where kids start doing things that really are over the top. So we had one boy who decided he was going to start a lawn service, which by itself would be great. The problem is, he didn't ask anybody if they wanted their lawn mowed, and he just took the lawnmower out of their garage and just started mowing. Mulch, flower beds, grass, mulch, flower beds, grass. He didn't care, he was just mowing. One of the neighbors called the mom and said, do you know what your son is doing? She went out and she was able to pull him back into the house. Not so good, so no judgment. I'm gonna make a bunch of money. So you see these symptoms all kind of mushed together. His mood was way up high, he was pretty grandiose, I'm gonna make $1 million, I've got this lawn service, and no judgment, okay. Another boy decided he was gonna start a baseball tournament. Fabulous. Lovely thing to do in the summer. Here's where the problems come in. He started by building the stands. So he goes into the garage and he gets these boards and nails and stuff, and he's kind of making a big mess in the garage. Then he kind of leaves it, goes up to the printer and prints out hundreds of tickets for the baseball tournament. And he goes around the neighborhood selling them. Okay. And there's a certain kind of, if you really are grandiose with an elevated, expansive kind of mood, there's a kind of a chutzpah that comes with it, like you're convincing, okay? And he was convincing. And he went around the neighborhood selling these tickets for the baseball tournament. Now here's the next problem. He didn't have any teams, and it was going to be in his backyard, which wasn't large enough to play baseball in, okay? So now when he's coming down, can you imagine how embarrassing it is? You live in this neighborhood and you've just basically made a fool of yourself in front of the whole neighborhood. We had a girl who in junior high was in our study, and when she started her period, she took a pair of white pants and a white t-shirt and a purple marker and wrote all over it with every vernacular term about I'm bleeding, I'm on the reg, I'm having my period, every possible terminology for menses all over this white pants and white t-shirt, and wore it to school. Okay. At which point I asked the parent, do you own or rent? Could you move? How hard would it be just to pick up and go someplace else? If you own, it's going to be trickier. If you rent, maybe it wouldn't be so bad. How do you live that down? At that girl's 20th high school reunion, people will be getting together and saying, do you remember that really weird girl? Do you remember that time she came in? People don't forget that. So you do these really odd things when you're manic. How do you live it down when you come? So it's not that hard to see how you can crash into depression, because you've just done this really embarrassing thing, okay? Looking back on it, it's really embarrassing. There's a lot of pain associated with that. Okay. Decreased need for sleep, this is what you have to be, and we'll talk about that, but it's really a couple hours less than usual. And then what I call the too muchness. You might always be kind of high energy, but suddenly it's got to ratchet way up to count. So the thoughts are just coming so fast that it's kind of almost gibberish coming out. And then really increased activity. Very poor judgment. We had a 16-year-old boy who came to our inpatient unit because he went down to the campus bar area and started picking fights with a bunch of college guys, like 4 or 5 college guys together, and he starts making insulting comments, and that's poor judgment at OSU to do that. You don't do that.